Hi, and welcome back to the NCS podcast, current series. This is Lauren Kaufman. I'm a neurointensivist at Temple University in Philadelphia. And today I'd like to welcome onto the podcast authors from a currents article, Traumatic Brain Injury in a Resource-Limited Setting, a reflection on the importance of timely interventions in neurocritical care. So thank you for joining us. Today we have Dr. Ramel Morel. He's an intensivist at Hospital Metropolitano de Santiago in the Dominican Republic, and Dr. Cleo Rubinos, who's a neurointensivist at UNC Chapel Hill. So thank you both for joining.
Thank you. Awesome to be here.
Thank you so much for inviting us.
Yeah.
Before we kind of chat about this topic, I'm just curious to hear how you guys know each other. Can you just share with us how you guys crossed paths?
Romel, you want to answer this question? I think you're the most appropriate.
Well, we actually didn't know each other until we decided to write the article. I sent an email to the current editor, so I let him know who I was, and I was interested in writing something for the journal. And that's how he gave me Cleo's contact. And then we started speaking. Then we spoke for like an hour. And that's where everything kind of came together. But we actually didn't know each other before. And it's been great to work with her. And she's been very patient with my crazy schedule, which is something I really appreciate.
Well, thank you for that. That's also a great plug for anyone to reach out to Mike Resnick, who's interested in contributing to Currents. We're always looking for new contributors. So before we kind of talk about how to think about addressing traumatic brain injuries in a limited resource setting, I'd love just to hear about what your practice is like, Ramel, in terms of, I guess we can start with what is like the emergency transportation services system like where you are?
So the main context of the article and the Dominican Republic as a whole is that we're actually the number one country for trauma-related deaths since last year. And it's something that it's really worrisome for not only from the healthcare point of view, but as a whole. And it's something that finally the authorities, the local government is starting to pay attention to. So basically, we do receive a lot of trauma. I work in one of the biggest hospitals of the country. It's a private hospital, actually, a private clinic. But we are right on the main highway of the country, one of the main highways. So we do get a lot of trauma. And we have a 911 system. It's basically called 911 as well. But the thing is that most of these personnel that's in the ambulances, usually they're not very well equipped and they're not very well trained, which is something that it's basically what we're trying to fight against. Because it's usually like a driver who has no medical training and a nurse or maybe a medical student or like a general practitioner that hasn't been exposed to any trauma or severe situations on his training. So that's something that usually affects how patients come in. And the fact that patients are usually the response time, I don't have any specific data recently, but based on my experience, from the moment that you call the 911 and they come, it could be from 40 minutes onwards. So it's really delayed when those first minutes count, especially about the brain.
Yeah, so it sounds like there isn't necessarily standardized or formal training or certifications for the people that are managing patients in the pre-hospital setting. Are there any
Exactly.
protocols? Yeah. Like, can they do airways, or is it really just really getting them to the hospital?
It's basically getting them to the hospital. They don't usually do airways. They are trained in CPR, basic CPR. They do start IVs when they need to. They usually are good at placing IV and immobilizing fractures if they need to. But that's basically airway management. It's one of the main concerns that we have, that there usually isn't any airway management. And something that happens is that since traumas are usually some way down the highway, there usually isn't a properly equipped center nearby. And what ends up happening is that the patient In average, they usually go to 2 centers before arriving to a center that's able to admit them, to take care of them. And usually what happens in those centers, when they come through the door, they see the state that the patient is in, they usually, oh no, we're full, or we don't have ICU, we don't have any neurosurgery or neurology, we don't have a CT, which is something that happens in most of our public hospitals here, that we don't have CT scans. So they usually just transfer the patient back to the ambulance to the next center. So that's usually first we have the delay from where the ambulance arrives to the scene of the accident, or wherever the patient is, and then the delay of the patient getting to where he or she can actually get help. And that time is really precious. And airway management is one of our main concerns regarding this, because usually we have to intubate the patients, most of them, as soon as they come in.
And so it sounds like you work at a higher level of care facility, but patients don't necessarily get triaged to the appropriate level. They just kind of get brought to the nearest hospital. Is that right?
Yeah, exactly. There isn't a like radio triage that can, or a dispatcher that can send them over to where they can be properly treated. They just get to the nearest hospital, and then from that they go somewhere else. And usually, what ends up happening, if you have like your private insurance and you get in an accident, you're probably going to be taken to a public hospital, since it's the public system that picks you up, unless there was family or something like nearby, or at the accident that takes you directly to the private hospitals. But if you go to the public center, then you're probably going to be there for hours until your family comes and then transfers you back to a private hospital. And like I said, public centers don't usually, they can manage airways, and sometimes they do, but they don't usually have either the medical staff to treat those patients, the physical space, or the images to do anything. So it's really most of the time when patients come in.
So it sounds like, there's
And
multiple.
like you said, lack of proper training. Like, it's the ones that are in the first contact with the patients are usually new graduates, doctors that haven't been exposed to trauma or to neurological patients, something like that. Yeah.
In the article you touched upon, there was a case described about how their patient was treated based on the limitations of the healthcare system and the triage network and the training. Can you think of a recent patient you took care of that might have had a traumatic brain injury, and how you wish things could have been done differently for that patient?
Yeah, actually, this is a topic very near to my heart. I lost my best friend to a car accident, and he was a third year internal medicine resident, and I was already doing my residency. And we worked at the same hospital. We were together since college. And like I said, the accident was very late at night, and he was at the accident like about 45 minutes before being taken at the scene of the accident, before being taken to the hospital. And when he came in, they intubated him, they called everyone. He had a severe brain bleed, and eventually over the next 24 hours he went into brain death, actually. So there's always each instance that or this little voice that says, what if they had intubated him before, or something like that. So when, I mean, he has a good neurological status, he hasn't had a seizure or anything like that. And we see that a lot with the cardiac arrest. Like, if the patient does it here in the hospital, his chances of survival are improved dramatically. But it's basically a matter of what we do in the moment for that patient, and basically managing airway, keeping a good perfusion to the brain and the heart. Those are the things that can and should be started from the moment the patient has the first contact with the medical staff outside the hospital.
I had no idea you had this personal connection to improving care. I'm sorry to hear that.
No, it's okay.
Well, we appreciate what you're doing to shed light on this topic. Switching over to Cleo a little bit,
Yeah.
why don't you tell us a little bit about, like, in terms of the data that we have, what do we know about how care differs for these patients in the lower middle income countries versus higher income countries?
Yeah, no, thank you so much, Lauren. Definitely the focus right now is in the pre-hospital care, because we know that a lot is different in the hospital care and also in the post-hospital care, who follow these patients too, that in the future we're going to be having an NC currents about it. But in the pre-hospital care, the data that we have one study that interviewed and saw into lower to middle income countries and included 5 countries in Latin America. And the majority of the patients are transported to the ER by a family member or by a taxi driver. There's not really any basic emergency transportation or advanced emergency transportations very well standardized within the majority of the countries in lower to middle income countries. And specifically in the Currents article, we mentioned the bootstrap trial or the bootstrap paper consensus. It was not a trial, it was a consensus. And specifically in the NCS article, we mentioned that bootstrap consensus, which was a beautiful paper done with our Colombian colleagues. And it was an impetus for the Minister of Health into improving pre-hospital care in Colombia, as is very well acknowledged that ABCs in traumatic brain injury actually can influence the patient's outcome. For this consensus, they got together about around 10 years or 8 years ago for 3 days and discussed what are the best pathway to triage the patients. And it was based on the severity of the trauma brain injury. And it also was it a basic emergency transportation or was an advanced emergency transportations. And it starts as simple as that. And they give you a beautiful algorithm that anybody just following up can see how they can manage the patient and triage the patient into where to take the patient. So even though you have taken the patient with severe traumatic brain injury and with basic emergency transportation, they tell you to look for pulses. If you have IV solution, give IV solution. If you find these like bradycardia and hypertension, give osmotherapy. If you have taken the patient to an emergency resource that doesn't have a CAT scan, doesn't have neurosurgery, so then you have to, with a severe traumatic brain injury, you have to connect to a higher resource center that have neurosurgery and critical care, not necessarily neurocritical care. And when you look in the consensus, it described in a step by step from starting for the pre-hospital to the ER and then to the admission of these patients. And it divides it within moderate, mild, severe, and then the resources that you have so they can guide the medical staff, triage the patient in the best way to give the most appropriate treatment that you actually can provide. So I thought it was a beautiful thing that they have established there. And I think similar to that, to create consciousness in other centers, in other countries, that they can probably do some policy changes with the Ministry of Health into implementing for distribution to the rest of the population or the rest of the medical staff to be able to bring the patient as soon as possible to a level of care that might be able to take care of the patient in the most optimal conditions given the local resources. So just to add a little bit, I'll pause. I have some data from status epilepticus management that I show at NCS meeting last year. We have 2 articles that have shown the management of patients with convulsive status epilepticus or with cluster seizures in the ER. These both articles come from Colombia, and 99% of these patients were brought to the ER by a family member. There's another article from Mexico, from Elma Paredes, that she described as well the admission of the patients with status epilepticus to her center in Mexico. And well, in her article, Elma Paredes, who described the admission of patients with status epilepticus to her center. And then she described how she's able to implement continuous EEG in certain patients by doing an innovative triage that she has implemented in her center. While she has not put how these patients arrived to the hospital in the paper, in personal communication with her, she said that also none of the patients were taken by any ambulance to the hospital. And this in Mexico City and one of the biggest neurological centers that the country has. All of them were taken by either a family member, a bystander, or a taxi driver.
Thank you. So, it sounds like there's certain groups that are working on putting together some protocols, but I know in your article you also mentioned some ongoing research with the motor trial. Maybe you could just tell us a little bit about that.
Absolutely. Roma, you want to tackle the other question?
Yeah, so basically it's like you said, it's the same scenario over here. Like bystanders and family members are usually who bring patients to the hospital doors. There has been, like I mentioned before, more hands-on approach from the Ministry of Health here. And we're getting like the public health system and the emergency response system is getting more resources, like more ambulances. And basically one of the main things that they're doing now, it's because the Dominican Republic, we have like four main cities, but it's we have a lot of of other cities where they don't have even access to any kind of specialty care, let alone a neurosurgeon or an intensivist, neurology. So one of the things that the public health system is doing or has been doing over the last 3 to 4 years is trying to get more of that specialized care to those other cities where there are a lot of accidents, because it's usually cities closest to the beach, or things, or cities that have some kind of tourist attraction, which is one of our main incomes actually as a country. And they're trying to open more ICUs outside those main cities to actually improve the care the patient receives before being able to come in and to the higher level centers, such as homes here at Santiago or Cedimat in Santo Domingo, or any other center that is able to take care of them. But I think we're still falling behind on that gap that we have to close on how trained are the people that are going to give the first response to the patient in those crucial minutes, the people in the ambulance, the people, because they are opening up like emergency medicine. It's a specialty that has been growing over the last 10 years actually here very exponentially. But those emergency responders, I mean, the emergency residents, the emergency medical staff, the seniors, and all that, they're basically still inside the emergency rooms and inside the emergency rooms of the big hospitals, both privately and publicly. So we still have to figure out how we're going to get those kind of medical staff that's properly trained more or closer to where they are needed in those times, and how to hopefully, like Cleo said, like do that triage before sending the patient over to maybe a center that's not going to be able to take care of them, and they just take them directly to a center where they are able to take care of them. So, but it's there, over here the scenario is that it's very different, that there's a lot of disparity between the public and the private health system, and that's something that needs to improve, because like I said earlier, if I have an accident coming out of the hospital and I don't have any identification, or either way, the probably the closest thing will be a public health center. So it can happen to me, it can happen to any family member, it can happen to anyone here in the country, in any of our cities. So it's not a matter of if I'm just doing private practice medicine, it's a matter of doing the better kind of medicine that we know how to do, also both equally at a public and at the private level. So that's something that also needs to be worked on, mostly through the medical societies, which is something that doesn't quite happen a lot, because usually the Ministry of Health is usually very related with politics here. In all of the lower middle income countries, there's a lot of politics involved. So that makes a lot of doctors and the medical societies, the specialized medical societies, to not usually don't want to get involved in a lot of public matters regarding the public health. But it's something that needs to be worked on going forward.
Thank you. Certainly a very challenging problem. And I guess, Cleo, if I think you're going to talk to us about the motor trial, which I think actually, like, part of the premise is using community members to assist, correct? In the initial, like, pre-hospital phase?
Yeah, it's a group of community members, but also medical staff, and they also working with the community traffic police. So yeah, the motor trial, what outlines is a protocol for a multi-center cluster randomized control trial in Uganda. They want to evaluate the impact of rural trauma team development courses on the care of motorcycle-related injuries. And what they're going to do is they're going to have 6 regional referral hospitals. They're going to be randomized into having the intervention. So they will have the rural trauma team development courses that will take the patients to those hospitals versus a control, which is the standard of care group. And then these participants are going to be mostly for trauma, for motorcycles, and the persons that are going to be in these trauma team, these rural trauma teams, are going to be care frontliners, such as medical care frontliners, such as interns, medical trainees, but also traffic law enforcement personnel. And then they're going to look into primary outcomes. So primary and secondary outcome, being the primary outcomes focusing mostly on specifically pre-hospital and referral exit intervals. And the secondary outcome is going to include all causes of mortality and neurological and orthopedic morbidities and 90 days post-injury. Entonces, using a standardized outcomes scale. And yeah, we'll be like really interested to see what this trial shows, especially because they are working, and they're establishing, I think for the very first time that I hear of, a collaboration with a community traffic police. I don't think I had heard that before, which is something very important to acknowledge and to perhaps replicate, as they are one of the first ones that arrive at these motor vehicle accidents in the lower to middle income countries. So they might actually help us triage the patient better.
Thank you. I think we're wrapping up here. So are there any final words or anything else you want to share with our listeners? It's something I know that you're both passionate about. Anything else you'd like to add?
I would like to add that I really want to thank Neurocritical Care Society for this global partnership in working with not only Spanish-speaking countries or Latin America, but also Asia, Africa, Europe. This really is what we're talking about, bridging the borders and making collaborations and helping diminish disparities in healthcare. Creating this type of audience has been, for example, Romel and myself work together and create this paper, which I'm sure has raised a lot of eyebrows and ideas in other colleagues and physicians as well. For example, I was in the coma campaign meetings, and also I discussed about curing coma in Latin America, and we brought a lot of great ideas, and I think all these health disparities, such as Romel has very well pointed out, are recognized by medical staff, but it's hard to do a change when you are alone. So having a critical care society putting us together and create a community of physicians that are able to pursue these endeavors and minimize these health disparities worldwide is super important. And I want to thank them because we could not do this without them. Something that I want to clarify or let the audience know is the difference between private and public hospitals in Latin America. So public hospitals are teaching hospitals, but they're solely funded by the government. And the economic foundation of them is quite unstable. And while this hospital has a high quality of the best medical intellect of the country, they don't have the technology or the resources to take care of the patients. Sometimes they don't even have CAT scans or MRI, as Romel has pointed out. And in the private hospitals, they have no link with the government whatsoever, but is pay out of pocket or paying with this high, very costly insurance. And mostly what they ask you in the private hospitals is, we'll give you the ICU bed, but you have to pay for 1 week or for 3 days in advance of ICU. Or we'll give you this medication, but you have to pay for this in advance. So your treatment is not always 100% forgiven, as you have to pay in advance. And you can imagine that creates more disparities. And this is very different because in North America, for example, I work at the University of North Carolina, which is a state hospital, a public hospital, as you will say, in Latin America. And we're very versed with all the technology. We do the publications for research. We have the latest treatment, the latest imaging, but that's not the same in Latin America. And that's why Romel was discussing the difference of where will you be taken care, or where will you be taken if you have a traumatic brain injury, because the resources might be limited, more so if you go to a public hospital.
Yeah, thank you for sharing that. I mean, I work at a safety net hospital in Philadelphia, and almost none of our patients have healthcare insurance. So it's crazy to imagine, not being able to treat someone just because, they don't have insurance and they show up and they can't get the care that they need.
Yeah, it adds up to the stress that we have. But basically, I want to join Cleo in thanking the Neurocritical Care Society. I feel very privileged to have been a part of this and to have met Cleo and and now being part of this podcast. I would like everyone to encourage anyone listening, especially our listeners from Latin America. As Cleo said, sometimes it's kind of a cultural thing over here that we see things like we feel alone, just like she said, and it's really hard to imagine like making a connection that might be able to spark a change eventually. But I think that's part of what we have been doing, and the fact that we're now able to discuss the article maybe in a bigger platform such as this, it's evidence that we have to take a chance, and we have to take the chances, as many chances as we need to be able to see that change happen, and especially when those changes in policies, those changes in care can eventually lead up to more lives being saved, and not only lives being saved, but returning functional adults and pediatrics patients back to their families as a whole, which is our main goal always.
Well, thank you again so much. Appreciate you joining. For our listeners, if you're interested in reading this or other Currents articles, head to currents.neurocriticalcare.org. You can access the NCS podcast wherever you get your pods, and don't forget to add us to your favorites so you never miss an episode.